in looking at the international flavor of this meeting, I'm pleased to be joined by a good friend and an excellent colleague, Dr. CM Yu. CM is actually from Hong Kong, so I'm glad to have you here, and thanks for taking the time.
Thank you, Randy.
CM, tell me a little bit about the practice of valvular heart disease in Hong Kong and even in China.
Well, the prevalence of heart disease, heart valve disease is actually increasing. We have a number of factors causing that, mainly because of the aging of the population. Perhaps also, with the evolution of atherosclerotic related factors, we have been seeing increasing prevalence of valvular heart disease. In our practice, basically, we try to manage patients according to the current established Western guidelines.
Okay.
Yeah, that means, patient with early stage, we might just carefully observe, regular echo follow-up, some medication as necessary. But then when they develop symptoms and also when there's echocardiographic evidence of severe disease, we might have to manage more, aggressively referring patient to a surgeon, or nowadays we just start up our TAVI program for aortic valve disease. For those patients without option for surgery, we might consider doing TAVI on a multidisciplinary approach.
So it's interesting that you're saying the same thing we're seeing: the aging population, inflammatory markers from the comorbidities is increasing it. One of the concepts that I think has really been good out of the whole TAVI thing is the concept of a heart team. Is that a reality or something that you're looking at in Hong Kong?
Oh yes, that is something definitely we are actually trying to follow and trying to form a strong multidisciplinary heart team. As you can understand that treating the heart disease with surgery and catheter-based procedures is something not a simple procedure.
Right.
And a single person cannot handle all this with potentially, transcutaneous root vascular complication, general anesthesia, contingency plan, and so on. A very strong and cohesive team will be the key of the success.
Absolutely, you're exactly right. The other thing that's interesting to me is that you and I were talking just a moment ago. Here we are at this fabulous meeting. We've got cardiac surgeons from all over the world and interventional cardiologists, but you've been a leader in CRT therapies and certainly have done some great work. What about CRT for functional mitral regurgitation? Tell me a little bit about your thoughts.
Well, in certain selected patients, CRT will definitely have a role, especially in my opinion, those patients who got a wide KRAS complex, those patients with demonstrable mechanical dyssynchrony. In fact, our studies and others found that patients with mechanical dyssynchrony after receiving CRT, there is not only reverse remodeling, but also reduction of the degree of functional mitral regurgitation. And interestingly, there is a good correlation between the degree of improvement of functional mitral regurg and the propensity of having reverse remodeling of the heart. So, these two factors actually go side by side.
CM, it's an interesting statement. Do you see how fast do you see the MR, and if it's successful, how fast do you see the MR change?
It could be as fast as a week.
Really?
And then it will actually carry over with the benefit probably from 3 months up to 6 months, where we will see the maximal benefit. And interestingly, our studies and others found that between 3 to 6 months, if we switch off the CRT device, in fact, mitral regurgitation do come back rather immediately.
That's interesting.
Yeah, therefore, there are factors that will be, governing the improvement of functional MR in CRT patient, namely a better contractile and coaptation force, the reduction in the degree of global dyssynchrony, as well as the papillary muscle dyssynchrony. I think these factors all play a role.
Well, it's a fascinating. I mean, it's really a dramatic technique if you get the right patient and it works well. So you right now you're really thinking the wide QRS is really something to look at. 150 milliseconds?
I will say 150 milliseconds. This group of patients will definitely respond better than those patients with borderline KRAS complex duration, namely between 120 to 150 milliseconds.
Well, listen, CM, I appreciate you taking the time to talk to us. You've done some excellent work in this whole area and also in valvular heart disease and run excellent programs in Hong Kong. So thanks for joining me.
Thank you very much, Randy.